So this is a study we are very excited about and looking forward to presenting at ASH. So we conducted a phase 2 single-arm study of patients with newly diagnosed Philadelphia-chromosome-positive ALL, Ph-positive ALL, looking at a combination of Dasatinib and Inotuzumab-based induction. So ultimately, we enrolled 21 patients on study, with the oldest patient being 79. There was otherwise, in terms of patient characteristics, a fairly good representation of both P190, which is about 2/3 of patients, and P210 transcripts, about 30% of patients. 19% of patients on study had a white blood cell count of over 70%, and 14% of patients on study had what we call the IKZF plus signature, which is associated with higher risk disease within Ph-positive ALL. And really what we were looking to answer is assessing the efficacy and safety of a Dasatinib plus Inotuzumab-based combination. So we enrolled 7 patients initially that were treated with Inotuzumab and Dasatinib concurrently for courses 1 and 2. In those 7 patients, we saw a major molecular response rate of 71%. And by that, I mean a BCR-ABL transcript that was less than 0.01%. And the other patients, the other 29% of patients achieved what we call an MR3, so less than 0.1%. By the end of course 3, where there was an option to switch from Dasatinib to Ponatinib in order to deepen response, the rate of MR4 went up to 86%. However, with the first 7 patients treated on study, we also did see veno-occlusive disease in 2 patients. So despite the very high efficacy with the initial schema, given this toxicity signal, we decided to amend our study and ultimately split the Dasatinib and Inotuzumab. So patients received Dasatinib during course 1, Inotuzumab as monotherapy during course 2, and then went back to TKI-based therapy at that time point. So with that switch, we did not see any additional cases of veno-occlusive disease, and efficacy was maintained. So 71% of patients by the end of course 2 had either an MR3 or MR4. And when you looked at the best response by the end of course 3, 93% of patients had an MR4 or better. We also used MRD assessment by NGS, which is at a sensitivity of 10 to the negative 6th. And of the 21 patient cohort, so all 21 patients treated, the MRD negativity rate at the end of course 3 was 90%. In terms of long-term outcomes, so the 2-year overall survival of our cohort was 80% with a median follow-up of 2.1 years. No patients needed an allogeneic transplant. There have been 0 CNS relapses, and there's only been 1 post-protocol systemic relapse. There have been 4 deaths of the 21 patients treated, 3 off protocol and 1 while on protocol. So ultimately, the EFS on this study thus far is about 76%. So in conclusion, a Dasatinib plus Ino-based induction has high rates of MR3 and MR4 after 2 courses of therapy. There was a signal of toxicity with the initial schema, particularly with regard to veno-occlusive disease, that has not been seen with our most recent schema, which splits the Dasatinib and Inotuzumab. Our study also demonstrates that it's feasible to deepen someone's molecular response if you switch them from Dasatinib to Ponatinib. All patients treated on study have either achieved a MR4 or MRD negativity by NGS, and the EFS on our study is 76%, and there have been no CNS relapses. So overall, this is a regimen that compares very favorably to TKI plus Blinatumomab-based approaches, with the added convenience that Inotuzumab is a once-weekly administration as opposed to the continuous infusion that you see with Blinatumomab.